Well, I'm really not happy with the airway stuff.
Okay. Nasal?
No, I'm okay with nasals. There's something else that you need. And did you check the cuff?
No, I didn't check the cuff.
You didn't check the cuff. You need to check the cuff to make sure it's good. But you touched the other one, so. Okay, cuff is good. Take that off and make sure, yeah, and then deflate it. Okay. But where's that stylet?
Oh, yes, the stylet.
Okay, very good. Okay, so I'm going to pass this tube around. I want you guys to feel this tube, the pliability of it. Okay. Now, you're going to put the stylet in the tube.
Do you like it? Do you not like it?
I don't like it personally, but and I never use it, but I leave it on this one just because, but I don't use it. Okay, so put the stylet in. Mostly the tip, yeah, I would feel the tip of it. Now when you're putting a stylet in a tube, you may want to lubricate it. Some of them are real slick, some of them are stiffer. It just depends. So sometimes you might want to put a little KY jelly or a little lidocaine jelly. Okay, the other thing you want to do with the stylet is you want to always make sure that it does not extend past the Murphy eye. The Murphy eye is the little port on the side of your endotracheal tube. Because what happens is when you're trying to intubate and you're pushing and pushing, this can pop through and you can perforate someone's esophagus if you wind up in there or if you wind up in the trachea or whatever. And I actually know of that happening one time. A friend of mine, SRNA, was intubated and that happened to them. So, as you can imagine. Okay, so it's right there. Okay, so now you felt the one tube, right? This one doesn't want to stay just because of the thing. Okay, now feel this one.
It's much more rigid.
What is the best way? I'll tell you, yeah.
Away from the patient? Or
Exactly, both. You don't want to poke your eye, you don't want to poke their eye, so kind of coil it up. I do all kinds of crazy stuff with it, yeah, to try to get it, but I have to make sure. You need to stylet your tube as a beginner, yes. Probably next summer, when you're a senior and you're starting to touch yourself, start trying on basic ones too, just not using it. I mean, which would you want me to put through your cords? You have to keep it all the way down if you're trying to feel the rigidity.
Oh, no, I didn't.
Oh, okay. Oh, okay. It's much more rigid, so you really, once it's like a crutch. When you no longer need the crutch, put it away. But you want to always have a styleted tube for emergency rapid sequence inhalation, because you want to get in on the first try. You don't want to take a chance. All right, great. All right, so now you're good. You've got, we'll just pretend because I don't have an OG and a esophageal stethoscope. So they're underneath there with the bear hugger, okay? They're right under here. Okay, this is good. I'm happy with this. You've got your two sizes of tubes, great. You've got your two blades, your airways, excellent. Okay, well, I want to cover these up because I don't want them to get nasty or anything with people coming in and out. So, okay, good, very good. All right, so now you're ready to go back here.
All right, so now I'm going to do all my medication.
There's syringes in there that you can use.
So for the day, I think that's should I just use the label?
Yeah, that's fine. Whatever's on there, just pretend. But you would actually label them. Also, if you notice, these syringes are labeled this way. I recommend that you put it this way for a couple reasons. One, you can easily see the date and time in your initials. Two, it's a lot easier to realize that this is ephedrine when the label's here than when I'm holding it like this. And I think it's purple and I can't really see it very well and it's wrapped around and, oh yeah, it is ephedrine, it's not neosynephrine. Okay? So I think if you do it this way, if you want to do both, that's fine, but if you do it this way also, it's really hard to see the date and time.
And then from there, you're going to assess how deep it is. Okay, so what do you need to do? So, and then what do you, why? I'm looking for fentanyl. There's remifentanil.
Yeah, that's what we're pretending right now because we don't have a fentanyl label.
So let's do fentanyl and Versed and propofol to begin with, and then I'm going to get some sort of neuromuscular agent out.
I think we should probably have sucks and rock uranium. You should always have a suck syringe There'll sometimes be some pre-filled suck syringes, manufacturerly labeled and pre-filled. If not, I always have a suck syringe ready with a vial of it, because you never know if you're going to need to use something to put in there, and they're difficult to ask, and you're not filling the airway after you induce, so you might switch from your depolarizer. You may switch from the non-depolarizer to depolarizer after you've gotten in there. You decide, I'm not going to use rock, I'm going to go with suck, because I'm not real happy. I can ventilate, but it's not easy ventilation. I don't want to burn the bridge. Okay.
Pretend like this is rocker room. I don't see
Okay, there was a rocker room. There's another name for rocker room that you may not know.
Semiron?
Yeah, that's it, Semiron.
Alright, Semiron.
How about some emergency drugs besides your ephedrine?
I got ephedrine, I have atropine here that I saw. And then I had a phenylephrine.
Oh, good. There was a pre-drawn phenylephrine. Great. I think it's right here. That's okay. This is good. Okay, so let me show you. So then you've got your needles and your syringes and everything. I'm going to use this for a second. Okay, so let me show you something. You see these? Soxabrachonium? And you see this? Ephedrine and phenylephrine. What do you notice about these? Right, that's a safety thing, okay? All muscle relaxants are red. Pressors are purple. Narcotics are blue.
That's everywhere?
Everywhere. It's a safety thing. Induction agents are yellow. Okay? Local anesthetics are gray. It's okay. You'll notice when you're looking at labels. I'm not going to ask you analysis, but just so you get used to it. So you got to always read the label too, because you may think you have A when you have B. So you should always reread, just like when you're giving your meds. So all those same techniques. Okay, and then the other thing I do is I always put my drugs in the order I plan to give them. So it depends which way you go. I personally go this way, but other people go the other way. I don't care how you do it, just so you do it. Where'd my remifentanil go? Oh, here it is. Okay, Remy. And my emergency drugs I kind of put back here. Okay, and then socks and rock. Okay, great, wonderful, very nice. Okay, so we're all good to go. All right, so let's go get the patient. Okay, so we go get our patient. We come back in, move them over to the table. Okay, go ahead. What are you going to do now?
All right, I'm going to have them move over to the table. I'm going to put the pulse ox on. Give them a little whiff of their stuff.
Perfect. How many milligrams are you going to give?
1 milligram to start, maybe 2.
She's a 34-year-old for lap fully 70 kilos. I'd give her 2. She doesn't have any other past medical history. She's really nervous. Yeah. Okay. Okay. Oh, but before you give it, you always want to, because that IV just dragged along the floor the whole way back here. Yeah, definitely.
Just keep a couple.
I actually do, yes. That's exactly what I do. And when my anesthesiologist comes in, I hand him the drugs, I give him alcohol drops. Half of them don't use them, but I at least try to. Because there's a lot of studies, really, there are. Okay, great. So you gave your Versed. Okay, you got your pulse ox on.
I would like to get a baseline blood pressure.
Perfect.
And then I'm going to EKG and kind of start pre-oxygenating.
Exactly, all at the same time. Yeah, you can put the mask on, especially if she's had the Versed, she'll probably talk. Just like that, and I leave it on the Christmas tree, like you may have to move it a little bit closer to your face, but that holds it for you, and you free up your hands to do other things. You just gently place it there, so go ahead and let it dry, right, turn your flow on, perfect. And make sure what is open? Yep. Is it open?
Where is it on the thing?
Yep, that's it. Is it open?
I'm not sure.
Good job.
About 6. About 6 when I'm pre-oxygenating.
Okay.
You need to make sure that's open, because otherwise it's like putting a straw in their mouth and saying breathe, and you kink it. And they're going, you can't breathe. It's like breathing against a closed door. Okay. Okay, so you've got all your monitors on now. There's another monitor you want to put on if you had it.
I mean the BIS.
And your,
I call it train of 4.
that's okay, nerve stimulator.
Okay. So that goes on the ulnar nerve.
Okay, so good. You're all monitored up. Your patient's comfortable. Yeah, probably I would do my esophageal because you're going to intubate this patient. It's better. It's a better monitor. Okay, so great. We'll call the anesthesiologist. Well, that's already attached to our circuit, so we're good there on the CO2 monitor, and it's on. We remember to turn it on. Yes, good. Okay, so great. Your anesthesiologist is here. Okay, so are you ready, Stephanie?
I'm ready if you're ready.
Okay, great. So why don't you ask her to take a few deep breaths? Let's really denitrogenate her, okay? So you're going to hold the mask a little more snugly on her face. Take some nice deep breaths.
Deep breaths for me.
Now, how will we know if our patient is well pre-oxygenated? What are we going to be looking for?
Looking for the nitrogen to be almost zero.
But our monitors don't show nitrogen, do they?
Mine yesterday.
It did?
Yeah,
It did? Okay.
yeah.
If it doesn't, some of the other ones don't. If it doesn't, what do you expect?
This one does.
I don't think so either. But if it didn't show nitrogen,
Do we have an end-tidal oxygen?
yes.
Yeah.
So what would we want our end-tidal oxygen to
At
be?
least 98 to 100.
Yeah, usually 95 to 97 is the highest you can get it. But so you have your FiO2 and your expired O2, okay? And you want your expired O2 to be above 90, usually 95. And that means they're reaching equilibrium, just like with our gases. Our inspired and our expired are equal, right? So, great. Okay.